really what we're trying to do today is, this is a new program, and it's so interesting seeing what's happened with CMS. A lot of interest in this program, had a ton of applications, 271 applications. Of that, only 128 got accepted. Looks like now only 110. And we are so fortunate that we have Dr. Yates-Lennon with us, because they're one of the ones that made it in. And we're going to talk all about REACH and the program and what they're doing. But before we do that, I would love to learn just a little bit more about you personally, as well as about CHESS, so we have some context for our conversation.
Sure. Thanks, Brian, and thanks for having me today. I'm really glad to be with you. Look forward to our time together. So, as Steve said, I'm the president of CHESS Health Solutions. We're a health enablement company, and our mission is to sustainably transform the healthcare experience for the patient, the provider, and the care team. We think if we do that, we'll move everybody down the road on the value journey. Our home office is located in Winston-Salem, North Carolina, although most of our employees today do work remotely following the pandemic, during which we learned a lot about remote work, right? But we serve mostly health systems and their employee provider groups in central and western North Carolina. We do also have as a client, or a value partner, as we refer to our clients, that's one of the largest FQHCs in the state of North Carolina, in the Gastonia area primarily. And then we also have a value partner that is an ACO in Northeast Florida. So that's our current base. We are looking to expand outside the state of North Carolina and have plans to continue to grow. Just as far as my journey goes and sort of how I landed in value-based care, I would describe my journey more as providence than ambition. I was a part of a 4-person OBGYN group. I'm an OBGYN by training, in a small town, Asheboro, North Carolina. It's just south of Greensboro, if you're not familiar with North Carolina. And in 2008, our group joined Cornerstone Healthcare, which at the time was a large multi-specialty independent physician-owned group. 4 years later, Cornerstone Healthcare would found CHESS as its vehicle to help Cornerstone begin its value journey. And so I've been around the company and its people from the beginning. I was telling you earlier, Brian, I remember the night we were sitting in a large meeting room, and the whole value concept was being presented, and we voted something like 80+% of the owners voted to launch into this journey. So I remember that night well. So from 2012, leap forward to 2015, I started to step away from obstetrics and got more involved in quality as chief quality officer for the medical group. Stayed in that role through 2018, when I came over to CHESS as their chief transformation officer, really responsible for business development and onboarding new value partners into our processes and engaging with them in the transformation process. Well, that was 2018. 2019, the president of the company at that time left for another opportunity. The board came to me and said, "Hey, would you consider being interim president?" And I said, "Sure, I'll be happy to do it. I didn't come here looking for this, but I'll be happy to do it." And then about 18 months later, I jokingly say I went on an 18-month job interview without knowing it. The board asked me to take the role full-time. That was January of last year. So from 2019 to now, it's at 3 years and one pandemic later. Here we are, and I'm have the privilege to serve with some amazing people here that really understand value-based care, are passionate about it, believe it's the right thing to do. So I'm very blessed to be here.
Really appreciate you sharing that background. And for those of you that don't know, Cornerstone, really one of the pioneers in value-based care delivery. There was actually a very interesting New York Times article about Cornerstone several years ago. And it really, when I think about the Cornerstone story, it highlights how complicated and challenging it is to really be able to do the right thing for patients and have the payment models work. And one of the things I think that Cornerstone did very well was spinning you out with CHESS. Then here you are, specifically purposed to be able to enable the groups to be able to participate in these value programs. And I think it's a really interesting model.
Yeah, and we chose the word sustainably in our new mission statement for a reason. It's really important that we create models that are sustainable into the future. And so it is probably, I mean, I'm an OBGYN surgeon, and I always laugh and say that, for me, it was pretty straightforward: either deliver the baby or don't deliver the baby. I just had two decisions. And now it is so much. There's just so much complexity, and it's not just complexity; it's complicated complexity. So, really, it's an interesting business. We're always learning.
Yes. Well, and it's like a multi-level chess game essentially. And it's like we're all trying to do the
No
same
pun
thing.
intended.
No pun intended. Exactly. One of the things about chess that I really admire, there's a belief, at least that I hold, when you think about value care delivery and success in these programs, it's very difficult to take care of patients differently. And one of the challenges is that for any given physician or provider, then if they're seeing 25 or 30 people today, everyone's in different programs. There's only a handful that are in programs. Makes it really hard to achieve. One thing that I think chess is doing that's really interesting is that you're participating in multiple different programs, trying to increase that density in a practice of where you're actually going to see different value. Can you share a little bit about what are the different programs that you're participating in, just so we have a sense of the breadth of value care delivery that you're doing?
Yeah, that's a great question, and you're exactly right. We do think that we need a broad portfolio, if you will, of options for providers and health systems to participate in. So, of course, founded in 2012. We started in the MSSP program in 2012, I think July, the first 6-month period in July of 2012, and have maintained a presence in the MSSP program since that time, of course, switching to Pathways a few years ago. 2016, we joined the Next Generation program, and it's in all-year-old class. Your comment earlier about CMMI, it's innovative models. Obviously, there's always some risk you take in going into these new models, but we've tried really hard to evaluate those as they're introduced and participate where we think it makes good sense for us and our value partners. So we, like I said, Next Gen, of course, we're 6 years in that program. That sunset in 21, and so in 22, right at the moment, we have an active MSSP Enhanced program, an active MSSP Track B program, and then are provisionally approved, pending all the final announcements and process that we have to go through for ACO reach next year. So as we look at our Medicare offerings, now we have, sort of 3 options for where we can land providers as they mature and develop in their ability to take on downside risk. We've got sort of a risk progression, if you will, to move them through. We've taken a similar approach in our Medicare Advantage contracts as well. So we have Medicare Advantage value agreements. Just as a note, we don't negotiate fee-for-service rates. Our value partners do that on their own, but we can bring them into our value agreements. And we've taken a very similar approach with Medicare Advantage and trying with every payer to have a shared savings agreement, a risk agreement, so that as our groups mature and perform better and they're ready to take on downside risk, that we can advance them along that journey. So for us, it's thinking a lot about how the health system and this provider group is performing, how the groups within the health system are performing, and even down looking at the individual physician level to understand performance. Over the last 4 to 5 years, we've added several commercial value agreements as well. And I believe we have one of those that is at risk this year, another one that'll move to risk in 24, and a third one, I believe, that will move to risk in 24. So we've begun adding those commercial agreements as well. We have a sister company, also an Innovator client, interestingly, here in Winston, that does Medicaid. And so we're also working with them, back to your comment, Steve, about, trying to spread value across provider group's entire population of patients, because what we don't want to do is come in and just slice up a practice by a payer segment, right? I think that can be very dissatisfying for providers. So again, trying to offer a broad swath of value options across multiple payer lines. So right now we have about 220,000 total lives in value-based agreements. 65% of those are in two-sided risk arrangements currently. And over the last 4 years, if you look at our average realized PMPY savings in our risk agreements, that's been about $650 a year per patient.
That's amazing, and I really appreciate you sharing the breadth of the portfolio and all of the different contracts. I think that's, it's really important to appreciate this whole journey that we're on. This isn't a fad that happens overnight. This is and you highlighted too, this is a decade journey, and we're only just starting to scratch the surface. And it really is something that it's very complex. It's the right thing to do for patients, the right thing to do for care. And timing is important too, as we learned, and also knowing the program and the program specifics. I have a lot of respect for our colleagues at CMS and CMMI. I think they're doing an amazing job of really trying to identify how can we create the programs and balancing out a very complicated country that's very diverse, and saying, how can we get more people in and have this work for more people? It's very challenging. And one of the things for you specifically, I always look at is, in your geographic area, you've got a low benchmark in some of the Medicare programs. And that creates a even higher hurdle then to be able to overcome.
Yeah, there's some stiff headwinds going in when you go in with low benchmarks out of the gate. So you're absolutely right. And it's, we have, we're very fortunate to have people who don't mind rolling up their sleeves and getting into the weeds of agreements with CMS and CMMI and the payers, and really understanding the levers within any given arrangement. Because I think if you've seen one value contract, you've seen one value contract. They can all be very different. They have different flavors, and trying to standardize some of that and get make sure that we understand it. And then, I think the other really important thing for us is getting that information, the right information at the provider-patient interaction. And there's a lot of work that takes place in the white spaces between provider visits. That's all critically important, and we can talk more about how that works. But for providers, it's helping them understand what they need to understand, not overwhelming them with all the minutia, but giving them sort of the why. And if they can ever kind of get a glimpse of what this can mean for their patients, you usually have a convert on your hands.
Absolutely. I think that it's really tapping into that purpose, that why are we doing all of this? The reason why we're doing it is because there really are opportunities to take better care of patients, and we need the payments to be able to support that. But it really is complicated, and the programs do have a lot of nuance. If we think about REACH, that this program, it's a very interesting program, and it's interesting also, how DCE was, and DCE became so popular in 2021. Really the enrollment really dramatically increased, and then with the new administration, they took a look and said, okay, we're not sure we really want to move in this direction. We want to move in this direction, but we want to do it a little bit differently, and made some modifications for REACH. Tell us a little bit about when you heard about REACH. What was the process you went through to really evaluate and decide about the program?
Yeah. Well, I'll start with the theme we touched on just a minute earlier, that it seems like the right thing to do. So that actually is what we looked at first. When you look at what the ACO REACH program really aims to do, which is promote health equity and address healthcare disparities in underserved communities, that kind of what left us with almost like a moral imperative that we needed to really consider this. And when we understand that the work that Atron Health Wake Forest Baptist will be our participant in the program, will be working with us in the program. They're doing great work already in the community. So it seemed like the right thing to do. A focus on provider leadership and governance, and that's something we've been big on since our inception, is provider physician leadership within the company, but also engaging deeply with physician leadership within our value partners. And then to your point about it being popular, I think one of the things that changed is they really wanted, the new administration really wanted to protect beneficiaries with more participant vetting. So making sure that we weren't just, turning this into a Medicare Advantage program by another name. So looking at all those things, they lined up well with who we are and what we do and the work that's already happening in our communities from the various value partners. Secondly, then we went to look at the financial model. And while obviously we would prefer to be in full risk and take on full risk, when we looked at the benchmark discounts in the model, even though I applaud CMMI for dropping it from 5% to 3.5% in years 4 and 5, still 3.5% discount to your benchmark, as you mentioned, when we already have a pretty low benchmark. That's a pretty big hurdle to overcome before you then can even realize savings. So what we did, and I'll say in addition to that, the Wake Forest has been in NextGen now for the last 6 years. So this is not a population that's not had some time in a value-based care arrangement. So pretty well managed as you can manage patients in those models. But what we did was we sat down and said, okay, we understand professional is only 50%. MSSP enhanced on the other side is 75%. What's the break-even point? What savings rate would the two programs be roughly equal? And when we did that math, and I shouldn't say when our CFO did that math, what we came out with was a savings rate that's pretty consistent with our historical savings rate. And so we felt like there was enough about the program in terms of trying to address health equity, focus on healthcare disparities, the opportunity to do work in sort of I'll call it capitation light model, that we felt like this was the right path for us to take. We also realized, and we've said this now a couple of times, that working with CMMI, it can be bumpy. We experienced that the first year in NextGen. There were a few bumps in the road that first year that we didn't see coming, but we found them overall to be good to work with. And so in spite of that risk, we felt like this was the way to go. But unlike I know many others that I've spoken with have gone to the global model, we just were not comfortable that that was a reasonable expectation to be able to overcome that 3.5% in years 4 and 5 and still achieve savings. And we're in it for the long haul. I mean, we're not signing up to get 2 years and then bug out without a penalty. So we're looking to be in it for the long haul.
Oh, that's really helpful, and I appreciate also, health equity. I think everybody realizes that this is a big problem and something that it's difficult to quantify and come up with models. So it's exciting to be part of something that's really going to experiment with this, and based upon those results, it certainly could end up in other CMS programs. It's interesting also to me how you kind of thought through the different elements in terms of, which category do we want to be in. One thing I'd be curious about, did you think also, in addition to whether you want to be global or professional, did you think about different provider segments? And how did you think about which providers and what network would really be suitable, or the ones that would be successful in this program?
Right. Yeah, we did. So we had 2 or perhaps even 3 different groups that could have, I think, legitimately and effectively participated in the program. One, just not quite ready to take that leap into that much risk. And the other was, yeah, we've done NextGen before. That's a little bumpy for us. Not sure we want to give that a whirl. So we ended up with Atrium Health Wake Forest staying in or moving into REACH, the other 2 staying in MSSP enhanced. And that's not all bad. I mean, I think given the complexity of the things that we'll have to deal with in terms of post-adjudicated claims and $0 payments, that we're going to have our hands full just working with a large academic medical center. Now they have, two 10s and of course multiple MPIs. But based on past performance, we really didn't give much thought to segmenting any of that group out. They've just been such high performers that, as an entity, they're ready to make the move.
That's amazing. It's really great to hear that, that you had some organizations that really thoughtfully said, hey, you know what, we like this conceptually, but we're not sure it's right for us. And then ultimately one saying, you know what, we want to do it. And it's interesting too that really including all of the NPIs, because this is a split tin model where you could make a decision, right, and some people have, but from a more from an equity point of view, saying, hey, if we're in, we want to be all in.
Yeah, it really is. And like I said, Atrium Health Wake Forest Baptist is already deep into doing a lot of work around health equity in the communities. And we can talk more about that in just a little bit if you like. But I think for us, the ACO reach is largely going to be harnessing that in a way that, can really drive performance in this program and get the kind of outcomes that we're looking to get in terms of reducing healthcare disparities.
Absolutely. Why don't we start to talk a little bit more about some of the specifics within the program and what you're doing to prepare for it? One of the things that I always think about with these programs too is that interventions take so long to actually make a difference. And that's one thing that you've seen, being in a program for a decade. Sometimes it's that multi-year. So when you have something new, it's like, boy, we need to get started right away. Health equity, as we were just talking about, is a big piece of the program. And so, so why don't you share with us in terms of your health equity plan, how you're looking at this? What are some of the things that you're doing in that regard?
Yeah, so there's a lot of work underway in various areas throughout the company. I'll start with just talking about voluntary alignment for a second, if that's okay, because at the moment, if I'm thinking about what are we working on today, we're working on voluntary alignment. This is a strategy that we've not engaged in our years in next gen from our peers that were also in the model. We just heard horror stories about how unsuccessful and challenging it was, and so never felt that it was really worth it. I think the model is set up and reach that there is the potential that it can be beneficial to your benchmark, and you can pull in some patients that you're caring for but just aren't being attributed. And I think it's one way to start bringing in some patients as they age into Medicare. Those folks, if you just leave it to the normal attribution process, it's a little while before they can be attributed. So looking at that as something, we're partnering with a company called Mabel, Mabel, that has a couple of years, well, probably more, but I know they've worked with multiple DCEs over the last 2 years through the voluntary alignment process. And so they're helping us there with the paper process. It's engagement. We're deep into education right now, not only internally, which I think that'll be a continual process for us, but engaging with the physician and operational leaders to just understand the ins and outs of the program, to finish building out our health equity plan. That's under development. Like I said, again, lots of work already underway before this program ever came out, working with our rev cycle teams within the health system so that they understand the process, understand what's supposed to happen with the funds flow, and aren't billing patients. We're working with our Innovator colleagues, so there's a lot of new demographic data to capture. So making sure that data is getting captured on the provider side and then hitting our data feeds from the EMR into our contract management dashboards and our primary care dashboards, all of which we're ready to roll out here this week. I have an email sitting in my inbox, so ready to go with that. And then as far as the health equity plan, there's a lot, obviously, that needs to be done. I've already mentioned data, just making sure that we're capturing that. Social determinants of health data is something we've been all doing in one form or fashion now for the last several years. We've got some screening tools that we use, and we're looking at a social vulnerability index or some other social risk scoring tools that are out there. But now I think it's taking on a new level of importance, and it's going to need to be incorporated into that patient 360 so we can pull that in and help better understand how those non-health related and factors are impacting a patient's health. I'll give you a great example. So in the last 6 months, I think our care coordination team was reaching out to a patient who had a poorly controlled A1C. They learned he was visually impaired, so he got referred to our social worker. Well, as you might imagine, he was having a great deal of difficulty with self-care of his diabetes, checking his blood sugar. He had a home aide that he had lost. And so the social worker engaged with the patient, got him connected to resources he didn't even know existed, got him lots of access to tools and technology that I didn't even know. Did you know there was a voice-activated glucometer? I had no idea. But he has now a voice-activated glucometer. And now his A1C is under control. Well, rather than just being happy sharing that patient story at our all-staff meeting, she took it a step further and said, let's look through the data and see how many other patients we have out there that have diagnoses that might indicate they're visually impaired. And so she didn't find thousands, but she found a significant number. And so now there's outreach going on to that population of patients saying, hey, did you know there's a resource for the visually impaired in your community? Let's get you connected. So that at the end of the day, I always say population health still happens one patient at a time, right? But it's that encounter that drove a very meaningful outcome for that one patient, but now creates and opens other opportunities for other patients. Particularly if I think about where Atrium Health Wake Forest Baptist is and the work they're doing around health equity, they continue to work on access. And I always tell providers, if I'm talking to providers about how can you impact utilization, I can't do anything about my ED per K or my AP per K. And what time does your office close is my first question. Oh, we close on Wednesdays at noon and Fridays at noon. And so, okay, well, you could do something about utilization if you had your office open more, right? So access is huge. But Atrium Health Wake Forest Baptist is leveraging their partnerships with FQHCs in some of their more rural areas, as well as free clinics, just trying to ensure that patients and the communities they serve have a medical home where patients feel like they belong. They've got really robust annual wellness visit and CMA, Certified Medical Assistant outreach programs around cancer screening as well as disease management. And I've touched a little bit on social needs already, but really focusing on acute social needs. So the story I just shared with you, although probably not truly acute, it could have gotten that way pretty quickly when you really understood his story and all of the things that were happening in his life and what resources he did have were being withdrawn because he needed to reapply, as well as just social determinants of health in general. Can we standardize our forms? Can we make sure we're using the same social determinant screening tools? And then how can we work with Innovator and others to be sure we're getting our hands on as much data as possible? So data at the zip code level, even the street level address sometimes, income, family members, all that data that we can pull in that gives us a better picture of the 80% of life that is not healthcare that really impacts a patient's chronic diseases and conditions.
Now that's.
I think I talked a long time. Sorry, I think I've already forgotten what the question was. So.
You gave such great information, though. I really enjoyed hearing it. I especially enjoyed hearing the patient stories and also the part too about population health is one patient at a time, which is obviously a little bit of a oxymoron there. But it's
right.
True though that you identify that one thing. The interesting thing is you identify something in a patient, and then you say, okay, are there others like this? And then so how can we do something that's going to scale?
Right. It needs to go both ways, right? I mean, we need to identify populations that have a need, but we also should not have blinders on when we see a patient with a need. Where are there others who have similar barriers?
Absolutely. So where we started with this one that really to kind of hone in for a moment is on alignment. And with a lot of these programs, that turns out to be really important. It's getting people in the program. With this particular program, there's both voluntary alignment and claims-based alignment. So claims-based alignment is where the patient has seen a provider, primary care provider for primary care services. The voluntary alignment is either beneficiaries could go online to Medicare.gov and electronically do it, or there's the paper-based alignment where patients could fill out these forms. And this is a very interesting thing because the alignment turns out to be really important. Maybe you want to share a little bit about how you're thinking about the alignment.
Yeah, so we are, like I said, we're working with Mabel to help us do this. They are using the paper forms. I think one of the experiences we had previously was for patients to go to Medicare.gov and have to go through that process was just challenging. And so they have, their experience over the last couple of years is that they've done better with paper-based alignments. That means we'll need to engage, office staff, and it has to be done compliantly. I think if I could say any word of caution, and this our experience with NextGen is they will audit everything. Mabel also, not putting in the plug for Mabel necessarily, but they do help keep up with the audit process for us on the voluntary alignment. So that was a big plus, was having some help there because we know it will be audited. For us, it was going back and trying to look in this with Wake Forest Baptist, Atrium Health Wake Forest Baptist, obviously a large academic medical center. And so thinking about, how do you think about voluntary alignment in that setting? So we sort of tried to recreate a little bit of a typical attribution model. Patients with Medicare, not in our ACO, 2 visits with a primary care physician over the course of the last 18 months. And so trying to use their data to identify those patients. And I forget how many there was, but it was several thousand patients, more than we would have expected. But if the process is successful and we get anywhere close to what Mabel says they've seen over the last couple of years, we could pick up several thousand patients in an ACO that's probably going to have, as it stands right now, if we just pick up our MSSP enhanced population and move it to REACH, it's going to be somewhere around 23,000 patients, I think. So to pick up a couple of thousand patients, that's a pretty significant pickup in the number of lives. And if they, Brian, you and I talked about this before we started, the voluntary alignment process is not totally straightforward. There is, just because they voluntarily align at the beginning of the year doesn't mean you'll stay that way. But nonetheless, if they do kind of stick, so to speak, in the voluntary alignment process, then there is a pickup on your benchmark for those patients. So, looking also at where we may have underserved areas that perhaps we don't have the same kind of attribution that we would like to see. So I guess hopefully that answers your question at how we're sort of thinking about that process.
Absolutely. And really appreciate also your point that, especially with CMMI, and again, I have a tremendous degree of gratitude and respect for the teams there, but they, at times with some of these programs, it really does require additional investigation and changes to be able to ensure that it's really keeping program goals. And normally voluntary alignment does take precedence over claim-based, but I've also heard to that point where if you do a voluntary alignment and then ultimately the patient is not receiving services from you after that point, that those patients potentially will end up, even though you would think voluntary takes precedence, they're going to pull those patients back, because really the whole point, you say, well, and part of this is going back to the why. Why do you have this? The reason why you have voluntary is you're going to be my patient now. So I want you to be included from today so that we could take care of you and have you included so that you count. I think it's a nice way of, like, we're not looking for people to game the system. And if you game the system, we're gonna find it out and pull it back.
Yeah, that's right. That's right.
So the other thing to talk about is the economics on this one. And so it's an interesting model from an economic point of view. And it was interesting to you start out with the benchmark discount. It's like it's such of an interesting term that's being used. It's like, how would you like to take a haircut, right? How'd you like
Right.
to
Well,
start?
I don't really want to take a haircut, just to be honest. I've had enough of one. So
I, I, I hear, I
didn't mean
hear
to throw
you.
you a curveball. Sorry.
Yeah, I like the curveballs. They make life interesting. So when you're looking at this program, then talk a little bit about that benchmark discount, and when you're thinking about, also there's a quality withhold on top of it, and also the other thing that's really interesting with this one is the risk scores, and so
Yeah.
boy, that's a and especially with the double indexing of the risk scores and the 3% cap. So we'd love for you to maybe unpack a little bit about how you're thinking about the economics, because again, the economics are important to be able to ensure that there's resources to take care of this patient population.
Yeah. Yeah. Well, so let me put out a viewer discretion advised. At the moment, I'm an OBGYN and you just asked me about economics. So you just waded into dangerous territory. I'll give you what I can. So the discount rate, that term, the first time I heard it, I really was like, what? I mean, what good is the benchmark if you're just going to knock 3% off the top of it to start with? But that really was the driving factor for us. And again, I commend CMMI. It was 5%. When they came out with DCE in years 4 and 5. I think it started at 2 and worked its way up to 5. Now it's just working its way up to 3.5. But still, that's a pretty sizable discount to your benchmark in a population where we have a low benchmark to start with. So that was, again, we would prefer to go to full risk, but 50% risk to do away with that bench. So the professional model, you don't have that. It's gone. So we just have our benchmark. So that was a deciding factor for us, because you add that 3.5% in, you've got 50% of that additional 3.5%. It makes a difference, right? The quality withhold, again, commend CMMI. That used to be 5%. They reduced it to 2.5%. I think the challenge is going to be for us. We're going to have withdrawals from the GPRO Wickham process as we move now to just straight claims-based measures and a survey measure. So it's going to be how accurately can we track that during the year, so we have some idea of how we're performing on the quality measures. And again, you need to earn that 2.5% back. If you don't, it just turns into another discount to your benchmark, right? So that's a big deal. As far as risk scoring goes, yeah, I would get in trouble really quickly if I tried to start talking about all the mechanics of the double indexing. But you're absolutely right that you're going to be compared to all the other ACO reaches. And one of our big concerns there is that the folks that have been at it for a couple of years now have really been driving risk scores and focused on risk adjustment coding. And that may create a bit of a negative for us. Not that we've not worked on it. We've been working on accurate coding and documentation for years. But I think there may have been, over the last couple of years, a sort of a heightened focus on that. So we have some concerns about that. Go back to voluntary alignment, though. When you have voluntary alignment, some of those restrictions get lifted a little bit. You get the true county rate. You're not adjusted down for that. And you also get the actual risk score, not an adjusted risk score. So it makes voluntary alignment meaningful if there's a population out there that you can voluntarily align that are not already aligned to you through claims. And the other thing we haven't really talked much about so far is that health equity benchmark adjustment. To be honest, when we first heard about this, we thought that's going to be great because we have a significant part of our population that we think would live in that top quintile. Is it quintile? Right. And so, but a decile, I'm sorry, not quintile, decile. And when the more we looked into it, we began to realize, wait a minute, this is budget neutral for CMS. And so when we ran the math, our finance folks took our existing population and tried to sort of recreate what we thought that would look like. It was budget neutral. And unfortunately, just because we move into this model doesn't make all of our patients who are in that bottom 5 deciles cheaper to take care of. They're already fairly inexpensive as the national average goes. And they didn't just suddenly get less expensive. So not creating any extra revenue in the model to help drive this, we were a little bit disappointed, and hope that we'll see that sort of change and evolve over time. So it won't just be a budget neutral adjustment.
Yeah, I appreciate you sharing that, and also share with you, coding has become a little bit of a third rail, and there's been, and we've tracked within the health affairs back and forth articles that the different points of view on it, and I think that in my heart, at least most of the people I know, what they're really trying to do is do accurate coding and really trying to ensure that, and like in any situation, of course, there's going to be some bad actors that do it in another way, but certainly I think that the goal really is ensuring that you have accurate coding, and even more so than accurate coding, by actually focusing in on the different conditions and understanding that really leads to then interventions, just like you were highlighting with that diabetes patient. So I think that coding is a natural extension of really being able to look at a population, understanding what disease exists, and then thinking about how are we able to take care of them. And so in that regards, if you want to maybe share a little bit about when you think about this population, even though obviously the program haven't started yet, but given your experience with all the other programs, what are you thinking about in terms of some of the different clinical conditions or some things that you're going to be looking at from a care management point of view?
Yeah, so I think a lot of that will dovetail very nicely, again, with work that's underway, as well as some of the other quality initiatives we're thinking about. So if I think about quality measures, for instance, the plethora of measures that we have responsibility for, the one that rises to the top of the list every single time in terms of the greatest ability, if well managed, to impact and improve morbidity and mortality in a patient's future is hypertension under control, right? So it's going to be focused in on, and that, by the way, at Atrium Health Wake Forest Baptist is a system level goal right now. So looking at that within underserved populations, looking at that within different ethnicities, and trying to understand where do we have more of a challenge and what can we do to address that. That work is underway. How can we harness some of that and help drive improvement in that area? And if we can improve that, we're going to have the greatest impact possible, I think, on improved health down the road for patients. And we all know that's the case. So that's one area that ties into things like, can we do remote patient monitoring? Hypertension control is ripe for remote patient monitoring. How can we piggyback on work that we know at Wake Forest is already doing in some of their, I think in their employed population, they're piloting some different programs. How can we learn from that and then scale that across this population using some of the waivers that we'll have access to, using some of the prepayment dollars to invest in these types of interventions. I think about, of course, you've got others, you've got other quality measures like diabetes, but also beginning to understand, okay, what about congestive heart failure patients? Those pop up on our list of, avoidable ED visits sometimes. How could we intervene earlier? Another remote patient monitoring opportunity. Where do we see the bulk of that condition? Where do we see it poorly controlled? Where do we see it advancing? We're having conversations right now with the nephrologist at Atrium Health Wake Forest Baptist. They've got one of the highest home dialysis rates in the country. So how can we help providers be sure that we're identifying CKD early, intervening early, and referring to nephrology early, so that we avoid crashing into the ED for dialysis. So those are just some of the areas that we're thinking about. And then there are all kinds of other social determinants that work that's underway, food insecurity. We have established over the last year within our current MSSP Enhanced program, and we've also, within our Enhanced program, a transportation program. So, many of the Medicare Advantage payers provide transportation. A certain number of transportation visits are trips a year from their home to the provider's office or wherever they need to go. That's not non-emergency transportation. So we work with Motive Care, and we, using the waivers within the MSSP program, have stood up a transportation program with them so that patients who cannot get from home to doctor's office for follow-up, in order to avoid a 911 call to go to the emergency department for a non-acute issue, they can connect with a care coordinator who will reach out to Motive Care, get a ride to their house, and take them to the doctor's office. So that's something that we've been doing. I see that being a part of what we continue to do as we move into ACO REACH.
Wow, I mean, Yates, you just gave a master's course on some amazing care management interventions, and so really encourage that. And we've got almost 260 viewers right now, so really encourage all of you that there will be a recording later so you can replay and hear each of those programs. It's so important, the patient identification, selection, and that's the interesting thing too. When you look at a lot of literature, then programs don't just succeed or fail because of the program. They succeed or fail because of how they're implemented, and it's having the right information that's available to monitor and track the programs. And you mentioned earlier a little bit about dashboards. So would love to hear from a program implementation point of view, what are the ways that you are using technology and infrastructure to really allow these programs to be successful?
Yeah, well, several different ways. As I was thinking about this, I'll start at the provider and then kind of work my way backwards up the infrastructure chain, if you will, or down the infrastructure chain. If you think about a provider at the point of care, what do they need access to? They need access to good coding tools, and that might be an EMR that does a great job of teeing up specific conditions, as opposed to just dropping a E11.9 in front of you every time you type in DIAB. 11.9 comes up. So it's easy to choose the most non-specific code. Some EMRs obviously are better at that than others, but I think that's sort of one point of care aspect. It also has to be in the workflow. I mean, I've seen EMRs that do a pretty decent job of showing a provider what opportunities are out there, whether that's open gaps in care or whether that's coding opportunities or whatever, but it doesn't fit their workflow. So it gets ignored or deleted or pushed to the side. So it's really important that that fits into their workflow. And they also need access to care coordination notes and the team. So, Innovacer has the EndNote application. We've not deployed that yet. We're soon to do that. And I love the feature of being able to communicate even in real time with the care coordinator, but for sure to be able to see the notes, the care plan, what's been happening there. And that's, again, depending on provider's EMR, can determine how easy or difficult that is. And then there are other overlay tools that can sit on top of the EMR, particularly as it exists in coding, recognizing that there are chronic conditions that haven't yet been recaptured or even some suspect conditions. We try to push away the payer suspect condition list because 80% of that is noise for a provider, and they will check out pretty quickly if you put that in front of them. If I move back up, then I start thinking about, okay, how do I let a provider know how they're doing in a contract? I don't want them bogged down in details, but they need a quick glimpse of, here are my patients, here are my open gaps, here's how I'm doing on my risk adjustment coding and accuracy. Here are the patients of mine who are hitting the emergency department, being admitted. And so using our PCP dashboard within Innovacer, I think is going to give us that ability to allow a physician to have a quick snapshot of how things are going in value-based care. And as we bring them into that, it'll take a little bit of time. They've not to date been used to having the ability to retrieve that themselves. It's been more of a conversation on a monthly or quarterly basis, but we look to move that to more real time and more frequent. And then from there, you're moving back up to leadership and saying, okay, how are we performing within a contract? If we're in that contract with other peers, then how does that look? How are we performing? How's the group performing as a whole? How our practice is performing? Can I drill into this primary care practice versus this practice? How am I doing by payer? How am I doing if you roll everything together, and giving them some kind of a real-time view into actual performance as much as you can. Obviously, claims lag behind, and that's frustrating. But one of the reasons we actually came to Innovaccer was their ability to take all these different data feeds and pull them together. So we do have real-time clinical data, almost real-time. We're taking in claims data and other payer files, which that can be a challenge sometimes. And then also companies like Bamboo Health, where we get ADT feeds. So we can almost in real time know when a patient's discharged from the ED or from the inpatient setting, from the skilled nursing facility setting, and can intervene so that that transition is a successful one. The patient lands safely back at home and is able to stay there because they know and have confidence they're taking the right medications, so they can actually afford their medications. And if not, that someone is helping them access medication, so that the inability to be on whatever they were discharged on doesn't cause them to then bounce back into the hospital.
Really appreciate you sharing a lot of that. And from Innovaccer's point of view, it really is an honor and a privilege to work with you. We've got a variety of different products that all work together and complement, and I know that you're using almost all of them. The InNode is one that hasn't been deployed yet. I think you're gonna be
Soon.
thrilled when you're gonna be thrilled when you see that one. That, interestingly enough, that's probably the one that's the most popular among our clients, because for the physicians to, at the point of care, just have that pop up and make it easy. So it'll be interesting when we do our analytics on our customers and our results. It turns out InNode is one specifically that really gets amazing results. So we're really excited to deploy.
Well, it's like it's a roundabout way to a registry. Many of the EMRs we work with have challenges identifying patients within the EMR. So that changing the banner color or having a flag or whatever to say this is an ACO patient, that's a challenge for them. Well, that tool only fires when the patient's listed on a contract. So by default, it is a registry. Which is really nice, because we get that question all the time. And how do I tell? And well, if it says United MA, probably is. And that's about as close as we can get sometimes, which is not a very rewarding answer to hear or to have to give.
It just gets back to really where we started a lot of the conversation. The details matter. And when you, for context, EMRs are a great tool, but the purpose of an EMR is very different than when you're trying to perform in a lot of these contracts. And so you really do need, as you've articulated very eloquently, especially with the complexity of the programs that you have, you need tools to enable these and make them work and bring them to life, and be able to actually operationalize and get results. And that's really something that we focus on, and we're really proud of our partnership. And especially, I know we didn't go into detail on this, but it's really nice how within the REACH program, there's a number of waivers. So you're allowed to provide these services that otherwise you wouldn't be able to. And again, all of this is just ways that we're able to better take care of patients and moving us along in the journey. Our time today has absolutely flown by. I feel like I know,
it's hard to believe it's been an hour.
We were just saying hello a moment ago, and here we are, really at our closing time. Before we sign off, I'd love to give you a chance there's a lot of people, that are listening. This, perhaps for some, this is their first CMMI program. For others, they're very mature like yours. What would you give us, kind of like a closing tidbit, closing remark? What are the final thoughts that you'd like to share with everyone?
Yeah, good question. So I think I said it earlier. Never stop learning. Always be curious, because there's always something to learn in these models. And I think having a curious mind, open to learning new things, it has to be the most important thing. Be prepared for audits. They will come. If you understand the program and you follow the rules, you'll be fine. We were with NextGen. And I think the last thing I really didn't talk about, and I would just say explore the waivers, because the waivers that are available are a lot like the ones in NextGen. And we focused heavily on the 3-day skilled nursing facility rule waiver in NextGen, and we'll have it next year in REACH. But we will look in 24 to expand some of those waivers as we start thinking about things like post-discharge home visits and that type of thing.
Yates, I really can't thank you enough for your generosity of time and also for your just authentic remarks and sharing a lot of your insights. And I know on behalf of Innovator and behalf of all the viewers that we had today, everyone really appreciates it. And so you've done a great service to us. Thank you.
Well, you're welcome. Thank you for having me, Brian. I really enjoyed it.
Absolutely. Have a great day, everyone.
All right. Bye-bye.